Welcome to this episode of the COVID podcast, where today we will be speaking to Dr. Patel. Dr. Patel is an assistant professor at the Rollins School of Public Health in the Global Health Department. As a social epidemiologist, Dr. Patel's research has been vital in learning about how contextual factors such as ethnicity, geography, and upbringing impact disease and mortality. This expertise is crucial when understanding social disparities within the pandemic, which we shall talk about in this podcast episode. Thank you so much for joining us today, Dr. Patel.
Thanks for having me.
So to start us off with the first question, can you tell us a little bit about your work and your research interests?
Sure. As Emma mentioned, I am formally trained as an epidemiologist, which means I study the distribution of diseases in populations. It's not just diseases, though, it's also risk factors for diseases. And over time, the field has gotten very open to studying broader socio-contextual determinants of health. So historically, we might have thought of risk factors such as behavioral risk factors like smoking or dietary factors now, and which were very specific and closely related to health, what we call proximal risk factors. Over time, there has been, I would say, more and more interest in more what we call upstream determinants of health. So the environments in which we live, work, and play, and how those factors affect health. So some of those characteristics might be broader socioeconomic conditions. I also do work globally, so I do look at things like how socioeconomic development globally impacts health outcomes of populations and that sort of thing. In terms of diseases, I actually focus on cardiovascular and cardiometabolic conditions like diabetes and heart disease. So that was actually, to some extent, my entry point into studying demographic trends with COVID-19, because there was this early and strong link between diabetes, cardiovascular disease, and COVID-19 severity. It seemed like there was an opportunity for researchers like me to contribute.
What is the COVID health equity dashboard, and what is, I know that that's something you created, so just what got you interested in doing that?
Yeah, absolutely. So like I mentioned, a lot of my work focuses on the social determinants of cardiometabolic disease. And one of the ways we've been doing that research is looking at county level characteristics and examining how county level environments impact diabetes and heart disease and other conditions. So I had a lot of data already on these socio-contextual determinants for my other research. When the early data on COVID-19 came out, it seemed like a major gap that we weren't looking at how COVID-19 outcomes were related to these social determinants. So this was in late March, early April that we first had this idea, and some colleagues and I got together and said, what can we do about this? Can we put COVID-19 cases and deaths in their socio-contextual into a social contextual framework? And so that was how the idea of the dashboard was formed. We then recruited a team, because I'm trained as an epidemiologist. I don't do data visualizations or sophisticated interactive websites or any of that as part of my work or training. So we paired up with some folks in computer science, and over time that team has really grown, and it's been a really interesting collaboration between people in public health, in clinical medicine, computer science. We even have some high school students who wanted to help out and have been doing things like finding data off the internet for us, because this is such a fast moving space. So I'm happy to share with you the dashboard itself that might put into context a little bit of what I'm saying. So this is the landing page of the dashboard. And on the very first page, you see an interactive map. When you're not clicked on any particular state, you see a summary of daily cases and daily deaths in the country. And you can also see COVID-19 mortality across the country by race. So for example, you can see that per 100,000, about 80 African Americans are dying from COVID-19, whereas that death rate in whites is closer to 62. You can also see, for example, that American natives have higher COVID-19 mortality than do white Americans. So this is the national picture, but as you hover over the map, you can see how this picture changes from state to state. So looking at our home state of Georgia, we actually see that at this point in time, if you look cumulatively of all deaths that have occurred till now, the racial gap in mortality between African Americans and white Americans in Georgia is actually quite narrow. If I click on Michigan, the state in which I was born and raised, unfortunately, that's not the case, and we see some very large and major disparities between mortality in African Americans and whites. So this is one of the things that the dashboard was designed to do, was quick comparisons across states. I'm going to go ahead and click into a state. So if you click on the state of Georgia, for example, you'll first get a repeat of some of the summary measures we saw on the first page. We also show things like the percent who tested positive in the past 2 weeks. And the reason why we do that is because that's an indicator of rising, it's an indicator of rising trends. It's also a measure of testing adequacy, whether or not we're doing enough testing. And a test positivity of 14% suggests that, you know what, we're not doing enough testing in the state of Georgia. You can go below, and this is where you see that county level map. And as I mentioned, we wanted to really put the COVID-19 burden in its socio-contextual context. So on the bottom side, you can see several charts that will compare the demographic characteristics of each county to the characteristics of the state and the characteristics of the nation. And that's what you see here. And on the top part, you can select to see cases or deaths over time. And this is how we can figure out whether cases or deaths at any particular time or historically are higher or lower than the state average, which is shown in gray, or the national average, which is shown in an even lighter gray. If you click into any particular county, you'll get more detailed health information on that county, including social determinants. Also, you'll see how those social determinants relate to various outcomes, COVID-19 related outcomes. You can get a data table and that sort of thing as well. And right now we're in the vaccination era. So we also have launched a vaccine tracker. And the vaccination tracker starts out with the national picture. So you can see that as of today, the data available suggests that 11% of the population is partially vaccinated and about 4% of the national population is fully vaccinated against COVID-19. You can also see a map of where different states are. So for example, in the state of Georgia, we have a slightly lower than average vaccination coverage rate compared to the nation. And then you can get just the general COVID statistics again. So this is an interactive website that we have created for policymakers, researchers, and others to better understand the COVID dynamics in a socio-contextual framework.
Wow, that is really cool. Going off of that, the dashboard seems to show a lot of data on a bunch of different things, but how can professionals use this to better tailor their COVID treatment, or how public health or policy kind of approaches all these issues?
Yes, absolutely. That's a great question. So one of the ways that people can use this dashboard is to monitor trends. And our original goal was really to target decision makers. We wanted it to be user-friendly for anyone, but as time went on, a couple of interesting things that I discovered was, first of all, there was a lot of interest among the public. A lot of times decision makers and researchers have have access to other special inside data, and or they have the data skills to look at, download data and maybe create their own reports and that sort of thing. But what we found is that the public has a large interest in using these data because you can make very quick comparisons. And so I don't know if 100 deaths per 100,000 is high or low until I look at the nation, until I look at other states and that sort of thing. And that's what the dashboard really can do. So I think it facilitates a lot of that data transparency for the public to understand, are cases rising or falling in where I live. Similarly, with the hospitalization data, we can show our hospitalizations at this time, another indicator of severity. Are they high or low at this time? What we're getting from the people on the decision-making side is we've been getting feedback that, the website is actually more user-friendly than some of the state resources and that sort of thing. And again, I think a lot of it is because people don't have to work out those comparisons. The comparisons are directly made for you. So you can get an idea if a county is trending high or low. The trend lines that we show, again, are trend lines that when I say trend line, I mean that epidemic curve that we're all tracking for our own county. If you see it in isolation, we're going to see those three waves. I'm sure we've all seen those three waves. We're watching it at the national level, maybe in our state. But again, it's only through that comparative view that you see, for example, Whitfield County is consistently high in all three waves. So we have to ask the question, why is that? Whereas we see Fulton County, for example, was higher than the state average, or rather higher than the national average to start out with, but then has kind of evened out and tracks more closely with the national average since then. So these are some of the things that you can find. The other thing that was a little surprising to me was that there's a lot of media interest. And I think that a lot of the topics that we work on in public health are pretty stationary, they're pretty static, they don't change they don't even change too much from year to year when it comes to rates of, say, diabetes or rates of heart disease. They're just small changes. It's rare that the public cares and that the media cares about them. Whereas with COVID-19, it's such a dynamic and such a powerful determinant of our lives today that the media also has an interest. And I'm finding that they also, the media at large, is a way of disseminating that information more broadly to people who might not otherwise have listened. So that's also, in terms of the viewership and the kinds of interactions we've had, that's been a bit surprising for me.
I think definitely. And just like, do you think that with the COVID-19 pandemic and, all the attention, as you said, the media attention, just like the worldwide attention that has kind of also helped people to focus more on general, socioeconomic factors that affect health in general, or the kind of disparities that we see. Do you think that has kind of brought more attention to that?
Absolutely. I think that's such a great question, and I think is a great insight. So within the first couple months of the pandemic, my colleagues and I were talking, and we were remarking that we'd never heard of so many people caring about controlling their diabetes as we did today. So as I mentioned, I work a lot in India as well. And I'm connected via professional and also other social networks to that country. And the amount of information that started going around on how to control your blood sugar, for example, just blew up because we realized it was a major risk factor for COVID death and COVID hospitalization. So it's not just about protecting yourself from COVID-19, which at large, and the protecting yourself from infection that people got invested in. It was also protecting oneself from these other more severe outcomes. So we definitely have observed that there is a larger space, I think, in the among the public at large, like a mental space and an emotional investment in understanding how they can live healthier and stronger lives. I would say that also when it comes to disparities, We've all been reading, I think, about things, reading and experiencing the dual pandemics of racism and COVID-19. And I think that what has happened through both the police violence that we saw in this country and through the pandemic is a new audience of people who weren't necessarily living those realities, observed those realities on television and through social media, and took an interest in just a way that, at least in my lifetime, I haven't seen. And so what has happened, it's been a disaster in so many ways on both fronts. I would say in terms of the social and political response to what has happened I think in Black communities with respect to police violence and the pandemic. At the same time, there is I think there's been an opportunity to build new solidarity. And I at least in, again, my social and professional networks, am hearing about people who had never previously expressed an interest in racial disparities or ethnic disparities or social disparities of any kind, talk about these social disparities, lament these social disparities, and people were interested in addressing these social disparities for the first time. So I do think it's a critical opportunity for those of us in public health to really do our part, I think, to educate people on what they can do and do our best to also be part of the solution.
As we continue the discussion about disparities, do you think that the COVID vaccination distribution in the US will be impacted by the social, geographic, and/or economic differences or disparities?
That's a great question. And it's not, at this point, it's not even a matter of what I think, it's what we're starting to see, unfortunately. So the same, social determinants that were placing communities of color at risk for exposure to COVID-19 and also worse outcomes from COVID-19 are also exposing them to lower access to vaccines. That's what we're seeing so far. So what I'm talking about is just the lack of it's a combination, I think, of lack of infrastructure and then also medical mistrust. And we know that medical mistrust is sort of built upon decades of mistreatment of communities of color by in healthcare and health research settings. But I think the vaccine hesitancy that we're hearing from communities of color, which is higher than what we're hearing in white communities, is due to that in part. But we also shouldn't forget that there is also vaccine hesitancy among healthcare workers that we don't often talk about. So for example, nurses. And then there's this intersection of where we know that a lot of, for example, African-American women are employed as nurses. So I think there are a lot of factors we have to think about on the hesitancy side. Then there are also factors on the access side. So there's been some incredible and unfortunately not surprising work showing that public vaccination sites tend to be disproportionately located in whiter communities. And so that's across the US South where that's been documented. I'm quite sure that if we were to look elsewhere across the country, we might see a similar picture. Do I think it's a conspiracy against communities of color? By no means. I don't think that that's what's going on. I think what's happening is that the vaccination distribution efforts are being built upon the infrastructure that exists that's expected. We'd want to be using things like these retail pharmacies. We want to be using primary healthcare providers that already exist. The problem is that those resources don't exist as frequently or as much as they're needed in communities of color. And so that, I think, is a major problem that we need to overcome. And equity in vaccine distribution isn't going to be just about having an equal number of sites in places. It's going to be having enough sites and enough resources to overcome some of these structural barriers. Also things like how are people going to get to those sites? So we need to be looking at where people don't have access to a vehicle. And especially in the US South, this is going to be a big problem in communities of color. And I'm talking about no access to a vehicle in places that have weak public transportation and that sort of thing. Where do people lack access to internet? Because we know that the internet is a critical lifeline to life in this pandemic, and also to making those vaccination appointments. We hear and read about how quickly those appointments are going, and the internet being crucial. So that's a bit about kind of the context, but what are we seeing in terms of outcomes? So what we've seen so far, of the 23 states that are reporting data on the racial distribution of those getting vaccinated, in all but one state, the share of the population that's getting vaccinated that's African American is lower than the share of the total population that is African American. So that's a problem. Another way of looking at this is at the national level. At the national level, our analysis suggests that about 17% of those working in healthcare that are prioritized through this phase 1A group are expected to be African American. But right now, the federal data suggests only about 6% of those getting vaccinated nationally are African American. So that's a huge gap. We can only understand that gap if we look very carefully at who is supposed to be vaccinated right now and who's actually getting vaccinated right now. We can't just look at the demographics of the population at large, because right now we know that it's not the population at large that's prioritized. So unfortunately, these are really worrying early patterns. I think, though, that there's a really important opportunity to course correct. And the first step in that course correction is going to be publicly releasing some of the data on who's getting vaccinated, where they're getting vaccinated, and who should be getting vaccinated. Because these are data that there are some data sources that researchers like I have access to. And then there are going to be other sort of more internal data sources that states and local authorities might have. They might have also done their estimates. I really do believe that we're going to be more successful if all of that is more clearly and transparently communicated to the public, so other people also figure out where they can pitch in. I don't think we can leave it just to the health departments. They're stretched, they're understaffed, they're underfunded. They've been working, around the clock since this all started. So I think that having some of this information in the public domain will allow other actors to also step in, public and private, to ensure that we're doing a better job in the vaccination phase of this whole thing as compared to what happened in the first 10 months.
No, I think I definitely agree with what you said. And then just another question that we had was that since you work at Emory in Atlanta, and then you work at the also work at the 4C Central Office in New Delhi in India. So could you just tell us a little bit more about how the responses to COVID have differed between the two countries?
Yeah, absolutely. It's been really fascinating because the responses differed in so many ways, and I would say the most striking way it's differed is the strong central leadership in India versus the more diffuse leadership that has happened in the United States, and also the very strong and decisive action of the federal government in India to order a national shutdown. So I'm not sure if all of you are familiar with this, but the country went into a national shutdown very abruptly that was ordered at the center. And that actually also introduced many problems. India is a country where a lot of people migrate for jobs outside of their home villages, their home states. So what happened was overnight, people were told that the country shut down, all business, everything is closed, like everything is closed. So those migrant laborers at first weren't, I mean, it wasn't clear how long. I think it was ordered for about 20 days to begin with. So that was a very long period to begin with.
Yeah, I think it
But
was like a 3-week lockdown because I was
yeah,
like, I literally just landed in India when the lockdown started and I just made
okay,
it. 'Cause otherwise, I would have had to be in quarantine, like, it like in Delhi, for three
yeah,
weeks before they started it.
right,
Yeah.
right. So it was about 21 days.
Yeah.
And at first, I think it wasn't clear to employers or to the laborers whether they should stay, leave, what. I mean, it took a couple of days to figure that sort of thing out. But then, employers were like, "We can't pay you if you're not working. We're not going to pay you." So then, and then the laborers, if they're not getting paid, they can't eat. So it was an incredible, incredible mess because then you had this mass movement of people from cities, laborers who are working in cities back to villages that otherwise probably were going to be untouched by the virus, or at least there would have been some time. So in a way, that national action, there's a lot of concern around the sort of the spread of COVID-19 that probably happened through that process and through it being a very disorganized and poorly communicated process. And also just the stress, the chaos. I mean, really, really tragic stories came out of that. So that's the downside. But I would say there was an upside in terms of, in general, having a cohesive messaging that we need to take this pandemic seriously. So I think that for me, that's been the biggest contrast, where in India, you have sort of leadership saying this pandemic is serious, protect yourself. And, to the extent of like, there were police involved with contact tracing and enforcing quarantine and that sort of thing. Whereas in the United States, we know we got a really different message. We got a message from different voices, depending on, where you lived, meaning what state you live in. You might have gotten a different message from your state leadership versus the federal leadership. Not to mention the, social networks. That's of course a different deal. So, the positive of that kind of clear communication and coordinated communication on the severity of the pandemic in India was that especially initially people took this very seriously. I think some of the downsides I've already mentioned in terms of what it did to in the time of shutdown in terms of the labor migration. There were also major concerns that the shutdown of the economy was not something that a country like India could afford. So that was another, that was a major concern. I would say another thing that came up in India is the stigma against people with COVID-19. There was incredible stigma against infection. I've heard stories, and you can read media accounts about people literally standing outside of the homes of people who were known to be infected and sort of, almost being blacklisted and gossiped about and that sort of thing. So I think that's a problem with overly simplistic messaging, saying that this virus is bad, avoid it at all costs, right? I mean, and this is something that unfortunately in public health, we keep forgetting that lesson. And also, it's not just about public health, it's also politicians. People are using this for their own purposes and that sort of thing. But in providing a clear message, we oftentimes do oversimplify and then end up stigmatizing the communities that we're trying to protect. So then there were all kinds of cases of, people not avoiding testing, or someone tests positive in your home. And let's say it's a middle-class home and there's household help, the household help would refuse to get tested and go back to their village instead of getting into quarantine, because they don't want to have the repercussions, the social and other repercussions of testing positive. I've heard cases of suicide around testing positive because people feel so guilty about what that might do to their family. So these are extreme consequences, but that's what we see in that country. I would say more recently, talking about the vaccination story, that's also been an interesting contrast, where there's a lot of federal coordination in India. Of course, there's some amount of federal coordination here, but we know that It's also broken down at the state levels. In India, for example, there's a co-win program and a co-win app it's nationally coordinated. So wherever you get the vaccine, you enter your information in this app, and the app will then say that yes, this person has been vaccinated. So that whole process is very coordinated. There's also, in the U.S. we have hesitancy around vaccines. That's like a historical phenomenon. It's not specific to COVID. But it is even heightened, or it's even more so in COVID because of the fast development and also some other factors along the way. In India, historically, there's not been as much vaccine hesitancy, but the government did choose to authorize a vaccine before it completed its phase 3 trial. So that has created a lot of concern about the political motivation and whether or not politics is basically taking precedence over the health and welfare, and politics and nationalism is being prioritized over health and safety of the public. So a lot of Indians are skeptical about the vaccine, especially the vaccine that was developed in India because of this. So these are some of the sort of contrasts that I see between the two settings.
Yeah, that's super interesting. Going off of like the political topic, a lot of people are thinking, at least in the United States, with the new administration, we seem to be turning a corner with how COVID is affecting our country. So, in your opinion, following the shift to a new administration in the U.S., have you seen or do you expect to see any major shifts in COVID spread or outcomes across different populations?
Yeah, that's a great question. So I think it's too early to say that any shifts we're seeing right now are due to the administration. We are seeing that this, third wave seems to be coming down, but that's probably due more to broader environmental factors. So we're over a lot of the holidays that brought people together, and you could see those spikes. You could see the cases rise as we had, and rise a few, like a week after Christmas, a week after New Year's, and that sort of thing. So, it's not surprising that cases are going down, and I don't think we can attribute that right now to the administration. But I do think that there has been a palpable shift in how this response is going to go. For example, there is now, federal attention to the equity issue. If you look at the CDC website, even, I mean, in terms of the leaps and bounds their tracking process has made, their data transparency since the new administration. And I don't have inside information to say that the two are linked. I'm just observing as an outsider that the communication from CDC, I think, has become much more transparent and has enhanced focus on equity. And then, so I think just the fact that leadership exists and that leadership cares about closing the social gaps in COVID-19 outcomes, I think matters, and it sends a message all the way down. I think it's also going to empower states to do the right thing where they want to do the right thing, because I think people want to do the right thing here, but there's been a lot of political interference. And I think the right thing is about clear and honest communication with the public. And that just was not, that wasn't the tone of the prior administration. That wasn't, I think a lot of efforts at the ground and state level were stymied by that federal sort of suppression of data and information that could have saved, I think, lives. So I'm very hopeful and optimistic that things are going to turn around. And I think that the fact that also with the vaccination approach, the Biden administration is taking meetings with state and local leadership on how we can do this better. And I think it is trying to be very data driven in the response. So that gives me hope that we'll be able to do better this year.
Hopefully so. I know everyone is getting a little tired of this current situation with being spread out and all things like that. So hopefully so.
Hopefully
But
so.
as a final question for the evening, what do you think society can take away from the pandemic in regards to health equity? And do you believe that goal is truly attainable?
Yeah, another excellent question. I really think that's the question that we should be asking ourselves every night, and especially for people like you who are students and who are thinking about careers in public health. One of the things I would say is whatever your vantage point is, whatever research you're doing, whatever area you care about, I think it's important to consider stepping up at a time like this. Okay, let me back up and explain why I said that. I think in academic research and in our training, we oftentimes get trained for silos, and we work. If I'm a diabetes researcher, I just work on diabetes. If I'm a cancer researcher, I just work on cancer. And so, and we don't necessarily talk to each other as much as we should, and we don't necessarily maybe pivot focus when something new comes up, because we see ourselves pigeonholed in these ways. So I think that from the training mission that I have as an educator, and that the public health practice mission or component of our work that you all might have as students or budding practitioners, should really think about how we can be ready to pivot when needed, and sort of step up to these kinds of challenges as a profession. So that's one lesson kind of for educators, and for the public health community at large. My colleagues at Emory have recently published a really nice piece on how we can learn from this pandemic in moving forward, and how the pandemic can teach us about public communication and science more broadly. And I think at this point we might not have all the answers, but I think the important questions to ask are clearly: public communication matters and science matters, and also the public interpretation of the science matters. Yet at top schools of public health, I think we're sort of woefully underprepared on how to bridge our science with the public's interests and the public's understanding. So I think that that is a gap we need to bridge in our training and our work in the future. And I think that's a gap that things like the dashboard can slowly chip away at, because we're trying to disseminate this information in a way that can empower the public to ask the right questions and hopefully help decision makers do the right thing. I think another thing we must remember is this shouldn't be a partisan issue. I think in the future we need to make sure that when it comes to it, really the welfare of all Americans should not be a partisan issue. I mean, there might be legitimate differences in how we achieve optimal outcomes, but I think what has happened over the past year, unfortunately, were sort of we got the worst outcomes due to partisan infighting and that sort of thing. So I think we need to figure out, how do we come to the table together to mount effective responses. It really, it shouldn't matter what state you live in. I mean, I think that's sort of the disgusting thing. It shouldn't matter what state you live in. It shouldn't matter what county you live in. And it shouldn't matter what race you are, in terms of your access to care and your access to resources to protect yourself against a pandemic, right? And so I think that keeping that message in mind, again with COVID, because the timeline from when you get this bug to the time you die is so short, and then it was so prevalent across the population. I think it's taught us that lesson in a different way. But this applies to all diseases, right? It really shouldn't matter. But let's think about how do we reorient some of our investments to minimize the impact of those sorts of structural inequities. I think also in general, broader investments in public health. I think if you look at it in the United States, I'll give the healthcare system some credit for how they responded to this. So if you look at fatality and that sort of thing, once you get to a hospital, your chances are much better now of surviving COVID than they were earlier on. It's because the healthcare systems learned along the way, and all the problems around resourcing and stuff aside, they're still better resourced than our public health systems. So I think we really need to invest in our public health systems, and not at the time of a pandemic. We need to make them strong and robust much before a pandemic comes, because again, the pandemic was a stress test that we didn't survive, that we just did not do, we did not perform well. The US is about 1/20th to 1/25th of the world population, but we make up closer to like 1/5 of COVID deaths. So just think about that for a moment, for the richest country in the world. So I think that we really need to step back and do a better job of funding our public health systems, or like our local and state health departments, so that when the next pandemic hits, or whatever it may be, they are better prepared to respond.
Hope that everyone takes your word under advisement. So thank you so much for dropping all this knowledge on us today, and just spreading this knowledge. The community really needs to hear this. So I really appreciate your time and the effort you put into here today.
Absolutely. And thanks for doing this. I think it's also important that groups like yours are coming together and having these discussions, encouraging these discussions. So thanks a lot for what you're doing.
Yeah, definitely. And I personally think that the equity dashboard is is an amazing resource. I feel like more people should just see it, because, just as as a bio student or just as a student, I think this would be far better than, actually going through so much of false data that's also circulating on the internet, and so much of false science that's also out there. And, just have a look at this to kind of get an overview of what's actually happening, especially, in a socio-economic context. So again, as Destiny said, thank you so much for taking time and talking to us today. We really appreciate it. And I think all our general body members and the rest of the Emory community will do so too. So thank you.
Thank you.